hello everybody. My name is Chris Lieu. I'm a GI medical oncologist from the University of Colorado Cancer Center. And today, given that it's Colorectal Cancer Awareness Month in March, I want to talk about two abstracts that were presented at this year's 2024 Gastrointestinal Cancer Symposium, otherwise known as ASCO GI. And the two studies I want to talk about involve circulating tumor DNA, or what we call ctDNA. And I want to talk about two studies. One is the BESPOKE study, and one is the GALAXY study, which is part of the CIRCULATE-Japan study looking at circulating tumor DNA in patients with earlier stage colorectal cancer. So I want to start out with the BESPOKE study. So this was an observational study enrolling roughly about 350 patients with stage 2 or stage 3 colorectal cancer. And patients had ctDNA drawn after surgery and then over the course of either their adjuvant chemotherapy or over their surveillance period. And what this study showed, and the investigator showed, were that patients who were ctDNA negative after surgery, and this was at one time point following surgery, they had a 2-year disease-free survival of around 92%, which is really outstanding. But if patients were ctDNA positive, their 2-year disease-free survival was only 30%. That's a tremendous difference in disease-free survival at 2 years. If patients were persistently ctDNA negative, their outcomes were extremely good compared to those that were either persistently positive or if they only had a transient clearance of their ctDNA. And interestingly, patients who received adjuvant chemotherapy seemed to only have a benefit if they were ctDNA positive, as the ctDNA negative group showed no difference between those receiving or not receiving adjuvant chemotherapy. They seemed to have a very, very good disease-free survival no matter what. Similarly, the GALAXY arm of the CIRCULATE-Japan study looked at patients in an observational way that had either stage 2, stage 3, or resected stage 4 colorectal cancer. And similar to the findings that we just described in the BESPOKE study, what we saw is that patients that were ctDNA negative, they had a 2-year disease-free survival of 94% in the all-time negative arm. And that means that they never had a positive test. But disease-free survival at 2 years was only 6.6% in the anytime positive arm, which means that they had at least one positive test in the surveillance period. Patients, again, who had sustained clearance of ctDNA appeared to have a really, really great disease-free survival, but patients with either no clearance of their ctDNA or only transient clearance of their ctDNA with adjuvant chemotherapy had worse outcomes than the ctDNA negative group. I think the really big take-home points from both of these two studies are that ctDNA really appears to be one of the most prognostic tests we've ever seen in colorectal cancer. And the emerging data really shows the impact of being ctDNA negative versus being ctDNA positive in their outcomes, at least at the 2-year mark. In addition, there's emerging data on what happens to patients with only transient clearance of their ctDNA on adjuvant chemotherapy, as well as just the impact of adjuvant therapy on patients that are ctDNA positive and negative. The other take-home point is that these are certainly just observational studies, and what we need in this space is really great randomized clinical controlled data. And this is the only way we're really going to know how best to utilize these emerging technologies moving forward. But I would say the data thus far is extremely promising. I want to wrap up with a neuroendocrine tumor study. The NETTER-2 study was also presented at the 2024 Gastrointestinal Cancer Symposium. The NETTER-2 study looked at the impact of what we call peptide receptor radionuclide therapy or radioligand therapy, or sometimes people call this PRRT, and was really evaluating PRRT on the frontline treatment for patients with higher grade, well-differentiated gastroenteropancreatic neuroendocrine tumors. We call these GEP-NETs. And in this study, patients with grade 2 or grade 3 GEP-NETs. So what does that mean? That means that the Ki-67 was somewhere between 10% and 55%. And these patients with higher risk disease were then randomized to receive PRRT with octreotide, 30 milligrams every 28 days, or octreotide at 60 milligrams every 28 days. And that was just octreotide 60 milligrams alone without PRRT. The study met its primary endpoint of progression-free survival, showing an improvement in median progression-free survival from 8.5 months in the octreotide alone arm to 22.8 months in the octreotide plus PRRT arm. That's a huge difference in progression-free survival. When you look at overall response rates, that was higher in the PRRT arm at 43% versus 9.3%. As expected, there were higher rates of cytopenias in the PRRT arm, but obviously the treatment was still very well tolerated. And I think the main take-home message from NETTER-2 is that this is the first randomized study to show an improved progression-free survival and response rate in a higher risk population and in the frontline setting. And I would say that this really shows us that PRRT really can be considered as a treatment option in the frontline setting for our GEP-NET patients. And we need to keep in mind the toxicities that are associated with this medication, as well as how doctors and their patients want to sequence out their therapy for their neuroendocrine tumors. And of course, with NETTER-2, we're also going to await maturing data on overall survival in this pivotal study. Thanks so much for taking the time to listen.